Thank you. And at the outset, I'd like to thank the chairs as well as the organizers for giving me this opportunity. So I'm going to talk on the translation of genomic knowledge in ophthalmic practice. At the outset, I have to agree that I'm not an ophthalmologist, but more a vision scientist and a geneticist. So what I'm going to talk about is on this slide, and I'll start with the paradigm shift in clinical practice. So basically in the 19th century, clinical medicine became more reinforced, and it was based on signs, symptoms, diagnosis and management. In the last century, it moved into preventive medicine, where you have target groups which you can screen clinically or biochemically, and then catch them early so that you prevent the disease. But in today's world, in this century, the field is more personalized and predictive medicine. So where you do deep phenotyping and you do all kinds of omics markers. For example, if I'm going to develop AMD in 5 years from now, so as a patient, I say that 5 years later, I can't read properly, and then I go to the ophthalmologist and they diagnose that I have AMD, but that it's too late to reverse the disease. So it's today that whatever molecular changes that is happening in my retina, in my macula, has to be picked up either in the tears or in the aqueous humor or in the serum, so that I'm going to develop AMD 5 years later, okay? And then you start to apply all kinds of preventive methods. So that's predictive medicine, and that's today possible because of genomics and various other omics that is available. So this is a central dogma of biology, where DNA finally becomes protein and then becomes an organ and an individual. But this central dogma is also becoming a central dogma of medical practice today. So at every stage, from the genome till the phenome, or the physical appearance and characteristics, we can actually intervene by various methods and block it, okay, or enhance it, whatever that you can manipulate, and either reduce the gene expression or you can actually enhance it. And therefore you can reduce the morbidity and ultimately the mortality. And that is the fundamental basis of my talk today. Now, how we apply genomic knowledge in patient care as a geneticist and a genetic counselor. This is a patient with ocular cutaneous albinism. Because of time, I have to rush through and cannot explain too many things. But the point is that this is the individual who has ocular cutaneous albinism, has reading disabilities, but she's a graduate. And she came across an individual with beta thalassemia, okay? So they got married. Now the question is whether the next generation will get either one of the disease, okay? I've been doing genetic counseling last three to 3.5 decades, and mostly patients come with one particular genetic disorder. But today the scenario is changing like the Western world, where both sides you have a genetic problem and they want to know whether it will affect the next generation. So to cut the long story short, we did genetic investigations. We knew that this lady had OCA2 gene variant. One was likely pathogenic, another one uncertain, but we are sure that is also causative. And her partner had a HBB variant, which is indicative of beta thalassemia trait. So we did what is called a carrier screening, and this is too much of information, I'm not going into it. But ultimately what happened is that with all that genomic screening that we did, or genome screening we did, we came to the conclusion that there is a 50% chance of recurrence of beta thalassemia trait in the next generation, and there is nil chance of OCA recurring, okay? Now that's the power of genomics and predictive medicine, personalized medicine today. And so we practice in many, many instances. I'm not going to go into too many of cases. Let me move on to the next part of my talk. How will the prescription practice undergo paradigm shift? There are many, many things happening. And in fact, we had a talk about stem cell. So there are gene-specific therapies and there are 300 genes. There are too many of them. It's not an economic model to treat each one of them because we have few hundred people with certain genes, and therefore, no company is interested. But agnostic therapy is sort of picking a bit of attraction now because it is non-gene dependent therapy. So the mutation directly doesn't cause the retinal degeneration. Okay, so it's inflammation, apoptosis, immune response, oxidative stress, many mechanisms that ultimately destroys the photoreceptors. Okay, so we can block all of them. And the biggest advantage is that it's almost similar, the methodology is similar to gene therapy, but then this is non-gene dependent. And therefore you can have an anti-inflammatory molecule, TNF alpha, or, antagonistic that you can prepare and put it in the eye. And the biggest advantage doing that is that it cannot not only apply for Mendelian diseases, but also for complex disorders. So you have malignancy or you have autoimmune disease. Most of the mechanism starts with inflammation, and therefore these kind of companies can survive very well and make profit simply because they can play on both sides of genetic disorders, on Mendelian as well as complex. So again, there is a battery of mechanisms by which you can block the protein synthesis with siRNA, mRNA, small molecules, oligonucleotides, cell-penetrating proteins. These are all not too much of up in the air story, but this is actually true. I'll show you why. So this is a nice paper about how cell-penetrating peptides can be injected into the eye, similar to gene therapy. And that's a list of ocular delivery agents of cell-penetrating peptides. I know it's a busy slide, but all that is going either in animal studies or in preclinical studies or in clinical trials right now. Okay, anybody who wants more information, I can give you this, but I'm not working in this area. So this is actually a pharmacological potential of small molecules for treating corneal neovascularization. Okay, so you can see a big list of them. There are many, many molecules, and some of the molecules' mechanism of action is not known, but still, Dr. Vel Pandian will know this better than me. But all this is coming true. So therefore, you have gene-specific approaches for retinal degeneration, gene-agnostic approaches. But gene-agnostic approaches, you have to start pretty early. You can't go at a very late stage. If it's a late stage, stem cell therapy is the best for any kind of cell therapy, which is again agnostic in nature. So they're also trying to revive embryological genes so that you have some kind of pseudo photoreceptors, but it has to be again started early. And again, I can give you this reference anybody is interested on. Oligonucleotides are coming up in a very, very big way. So the DNA, the biggest advantage is that they're complementary in nature. So you put a small DNA, it'll go bind to the genomic DNA and block its activity. So there's not only ophthalmic, but there are many other fields, and all these are available across the counter now. Okay, it's not something that is sitting in clinical trials. So small molecules are basically where you get very small fat molecule, and you can put anything into siRNA, peptide, or a small DNA, microRNA, and so on. So therefore, you can inject them into whichever cell or tissue that you're interested in, and then they can simply act and produce less morbidity or inhibit the deleterious mechanisms that are happening in any part of your eye. Okay. So these are exosomes. Again, as I mentioned, there are quite a lot of them going on in research, again in ophthalmology, besides other fields of medicine. So with that, I come to the last part of my talk. So what is the future now? Okay, where are we going towards? So like doing any other investigation in your clinic, it is mandatory that you have to screen the genes. Okay, of course there is a need, you have to do it. There's no way that you can have a child with a genetic disorder and you don't do a genomic screening. So this slide tells you that this is a traditional care pathways. A child comes with congenital cataract, what people did. for the last century is that they will sit and wait and watch what are the symptoms that are appearing, signs and symptoms in the child, and they'll make a diagnosis, syndromic or whatever. It will take 3 years, okay, but all damages are done by then. But today the child comes in with congenital cataract, so you screen with next-gen sequencing, and then you know what the gene is, okay, and then you start to see what signs and symptoms will appear. Accordingly, you can sort of counsel the parents, and they can go for the appropriate rehabilitation services and help the family and the child to recover faster, okay, and then integrate into the society. Okay, so therefore I'm come to the last slide summary, and so I spoke about the paradigm shift. We are in the era of personalized and predictive medicine, and we do genetic counseling using genomic screening, and then there are lots and lots of changes happening, and the way you clinicians are going to prescribe medicine is going to change a lot, and I'm sure Professor Will Pandian will be able to answer the many questions that you might ask after I finish my talk. So the future is you have to do a genome screening. So as a clinician, you suspect a bit of genetics or age-related disease, it's AMD or diabetic retinopathy or any kind of degenerative disease, you have to screen the genome. Okay. With that, I come to the last slide of mine. And so I work for Narayana Nethralaya, so there's a clinicians group. You can see Dr. K. Bhujang Sethi as well as Dr. Roy Sethi here, and this is Professor Shomi Bhattacharya. This is a research group, and Dr. Arka Ghosh, Debashis Das manage that part of the Narayana Nethralaya. These are my students in Chennai, PhD students who I guide, and they help to get this talk done. So I'm thanking them. With that, I finish my talk. Thank you.
Thank you very much, Professor Kumar. Time for a quick question.
I have questions, but
If you ask question, Professor Valpandi, you have to answer it.
we'll talk it over.
Okay, go ahead, yeah. Yes, please. Question. Yes, madam. In India, we have no other choice. The costs are coming down, and it's sort of most of the screening that you do now is under 20,000 rupees. 15 to 20,000 rupees. And mostly the patients come for premarital counseling, and then preconceptional, and then prenatal. For these reasons they come, and then you screen them, or it could be for clinical diagnosis where they missed or they suspect a syndrome, where all you can help. But in India we have to pay from the pocket, and many parts of the US also, not that every state gives you coverage for genomic screening. Okay. Yes, again, having finished my talk, genomic screening is not as easy as I told. There are many issues that we are facing, particularly one called as variant of unknown significance, and this is a nightmare in the field, where a particular change we don't know is causal of the disease or not. But then there are many other ways by which you can confirm it. So therefore, for example, in my particularly retinal degenerative diseases, your hit rate is pretty high. Unlike a few, like for example, neurodegenerative diseases, childhood related, the hit rates are very low, so comparatively.
All right. Thanks very much. I think we have to move on. Thank you, Kumar.
Thank you.
We can have more discussion later. Thank you.